I'd like to go ahead and introduce our presenter, Erica Botting. She's the Central Florida Regional Consultant for HIV and AIDS Surveillance with the Florida Department of Health with Hillsborough County. Erica?
Hi, everyone. Okay, I want to thank you for allowing me to present today, Hilda. I appreciate the invitation. It's very good to be back here at my alma mater, USF. And thank you to all the participants today. It's good to be able to share this information with our community partners. And so let's get started. So the objective of today's webinar is to basically give you what, who, how, when, where, and why reporting is reporting in the state of Florida. I'm going to give you an overview of a little bit of everything. We're going to talk about lab and provider reporting just to give you the full scope of reporting, and then to end it with some resources for you. But let's first start by looking at history. So we don't know where we're going if we don't know where we've been. So historically, in 1991, we know that the CDC first identified the first case of AIDS. And that's when Florida began to voluntarily collect AIDS surveillance reports. In 1982 is when the CDC first published its first case surveillance definition of AIDS, and then in 1983 is when AIDS was designated as a reportable disease by the state health officer, and a formal AIDS surveillance program was instituted in Florida. Then in 1984, HIV was discovered as the causative agent of AIDS, and then in March of '85 is when we had our first blood test that could detect HIV antibodies. Mandatory reporting of AIDS was incorporated into the Florida statutes and the Florida Administrative Code, and that directed all AIDS cases to be reported to your local county health department, and that was by the physician of diagnosis. In 1987 is when the CDC revised its case definition to determine HIV/AIDS in children less than 13 years of age. In '88, the Florida legislature passed the Florida Omnibus AIDS Act, and what that did is it prohibited discrimination against persons who have HIV or AIDS. And then in 1993, there was a significant change in the AIDS case definition. And what that did was include persons with an absolute CD4 count of less than 200 and or less than 14%, and then added 3 new indicator diseases or opportunistic infections. In '94, wasting syndrome was included as part of the HIV/AIDS definition, and then encephalopathy was included as indicator for HIV/AIDS in children. In 1986, we had amendments to the Florida statutes and the Florida Administrative Code, that's 64D, and that required laboratories and physicians to report positive HIV infections. But July 1st, 1997 is a significant date in our surveillance program because that is when HIV infection became reportable by name in the state of Florida. There was also an amendment in 1998 where the Florida statute required medical examiners to report HIV positive tests. In December 10th of 1999, with an effective date of January 1st, 2000, the CDC established a new case definition for HIV infection in adults and children. And what this did was revise the surveillance criteria for HIV infections and then HIV-exposed infants. So those newborns that were exposed to HIV from an HIV-positive mother, that event became reportable. In the year 2000, the NAT test was adopted. That's the nucleic acid amplification test, and that's when the American Association of Blood Banks adopted that as part of their criteria for screening the blood supply. And then in 2004, rapid HIV testing begins, and that's where someone could get a result on that screening in about 20 minutes time. So we talked about the revision in the year 2000 to the CDC case definition, but it wasn't until November 20th of the year 2006 that the Florida Administrative Code, so Florida's laws, allowed our surveillance program to actually require providers to report, and we could then use that case definition to those reportable diseases and conditions. So what that meant was we could change our surveillance definition and then expand the number of cases we could report. We could use viral loads, detectable viral loads as part of our case definition now, as opposed to just using diagnostic tests that are antibody-based tests. And then also that time, Providers were now required to report all HIV-exposed infants less than 18 months of age that are born to an HIV-infected woman. And that law persists today. So if you're a provider out there and you treat women who are HIV positive, when she delivers her newborn, that event is reportable to your local county health department. Also, part of the Florida Administrative Code 64D-3 again has a laboratory reporting requirement. And what that does, it breaks down the type of lab tests that are used to report HIV or to diagnose and treat HIV positive patients. And so laboratories are required to report positive HIV confirmatory tests, and they're also required to report positive virologic tests, being detectable or undetectable, and then all viral load results, and then all CD4 counts and percentages. That is, all CD4 counts. Now we know that the CD4 count itself isn't part of or exclusive to HIV positive patients, but it is part of the case definition for AIDS. So in the event we get low CD4s, that's when your surveillance office may be contacting you as a healthcare provider to determine if that patient is in fact HIV infected. And then also laboratories are reporting all HIV test results on positive or negative on those patients that are less than 18 months of age. And that assists us in our surveillance case definition to ultimately determine if those HIV-exposed newborns are in fact seroreverters or seroconverters. And then in December 2008, the CDC once again revised its case definition, and this is the surveillance case definition. And as I talk here, we're talking surveillance definitions. They're not specific to clinical diagnoses or treatment. This is purely for surveillance and the data, and then the population-based data that we use that for. So the CDC revised its case definition again in 2008, and then what that did was made laboratory confirmation of HIV infection a requirement to meet the case definition for HIV infection. And then 2014 is our most recent revision to the surveillance definition. And what this does is combine surveillance case definitions for HIV into a single case definition for all persons regardless of age. And then these revisions were essential. In the most recent years of diagnosing HIV positive patients, we have new testing algorithms, some advances in HIV testing. You may have heard it called fourth generation testing. And with this advanced testing, we're able to determine or find more acute cases. We're able to differentiate between HIV 1 and 2. So the revisions to the surveillance case definition allowed us to reflect those changes in the diagnostic criteria. So what exactly is disease surveillance? Disease surveillance is not the same thing as law enforcement surveillance. We're not in the bushes. We're not keeping track of people. Disease surveillance is about data collection and then using that collection towards other efforts. So specifically, it's ongoing, it's systematic. We use that for interpretation and then dissemination, and then we use it to evaluate population data to use it then towards persons diagnosed with the disease or reducing further infections. In HIV needs surveillance, we're looking at the full spectrum of disease, the full spectrum of morbidity to mortality. So that may start at HIV exposure in children, or it might be just the initial diagnosis of HIV infection, that first positive confidential test. We then are tracking a patient's first CD4 and their first viral load test. Hopefully that is occurring at the initial stages of infection. We're looking to get patients linked and engaged into care sooner rather than later so that we can keep their viral load suppressed so that they stay healthier and that they're less likely to transmit that disease to others. Further on in that spectrum, we're looking at possible CD4 counts that are less than 200, which is AIDS defining, and or an opportunistic infection, also AIDS defining. And then that spectrum of surveillance ends at death. So a good surveillance system has dual reporting. It has reporting requirements of both physicians medical practitioners and laboratories. So the Florida statutes, it's section 381 of the Florida statutes and then 64D-3 of the Florida Administrative Code states that all licensed providers and laboratories in Florida are required to notify the Florida Department of Health of diseases or conditions of public health significance. I'll specifically talk about HIV and AIDS, but there are other diseases and conditions that are required of both physicians or medical providers and laboratories. So healthcare facilities might have both a laboratory and medical treatment being provided. For example, in a hospital, we know hospitals have their own laboratories. So when in essence they have a lab and medical treatment at the same facility, both practitioners and the lab within that hospital are required to report under law. So lab notification of test results does not nullify a practitioner's responsibility to also notify the Department of Health of the disease or condition. Reason being, laboratories are providing lab results. They don't have the full scope of a patient's condition. They can't give us modes of transmission. They can't tell us how the patient, if they're on treatment, what treatments they're receiving. So that's the difference in lab reporting and provider reporting. Lab reporting is simply a lab result where that provider is going to give us the full scope of the patient's treatment care and even their testing history. So dual reporting really depends upon the cooperation of physicians, laboratories, our infection control practitioners, and then we use all of this information to monitor the health of a community and to provide the basis for further action. So what you see in front of your screen now, I know you can't see the full thing, but I do have a website there for you, and no need to write it down. We'll have resources at the very end of the slide set, and then we'll provide those to anyone who requests them. This is a reporting packet or reporting guidelines. This is the lab version, and it's the guidelines for reportable diseases and conditions in Florida. And again, this is a document that was based on the Florida Administrative Code, and this is the most effective date, most updated is June 4th of 2014. And this is a guide produced by the Florida Department of Health to assist laboratories with their lab reporting requirements of all diseases and conditions. Similarly, providers have a version that they can refer to. And again, this is available on floridahealth.gov, and we'll send those resources out to anyone who wants to look at that. But it has frequently asked questions. It lists a table of diseases, all diseases and conditions reportable. It has the time frames. So if you have any other reporting questions other than HIV or AIDS, this is a very good resource for you as a healthcare provider. Okay, so this is the nuts and bolts of what the Florida Administrative Code has. And this is something that I pulled from the table that is also in the reporting guide I just mentioned. And this has both the practitioner and the laboratory requirements. If you notice on the left in blue is the practitioner reporting side. And it has it divided by the disease or condition and then along with the time frame required for reporting. So for AIDS cases, practitioners should be reporting anyone they treat or diagnose with AIDS within 2 weeks of that treatment or diagnosis. Labs, on the other hand, do not report AIDS cases. AIDS is a syndrome. There is no AIDS test, so there's no reporting requirement for laboratories when it comes to AIDS. Inversely, CD4 results are reportable by the laboratories. They report all CD4s, absolute counts, and percentage of lymphocytes to the state health office or your local health department, and that is to be done electronically. Whereas CD4 counts alone are not indicative of an HIV positive person per se. It's indicative of a possible AIDS diagnosis, and so that's where if we receive a low CD4 count, which is a count that might be indicative of an AIDS case, your surveillance officer will be contacting you as a provider to possibly rule out HIV infection. And keep in mind, there are other diseases and conditions with low CD4s, as we know, but that doesn't mean that those persons with another condition can also be HIV infected. So we always recommend that we test and screen for HIV infection in all patients. Now for HIV, the virus itself, providers also have a 2-week time frame for reporting. That is by mail or phone call, and I'll show you some resources for that in a moment. And inversely, the labs that are used for diagnosis and treatment, so that could be any repeatedly reactive enzyme-linked immunoassay that is followed by a confirmatory test such as a Western blot, a positive result on any virologic test, a NAT test, for example, or a viral culture, and then all viral load results, detectable and undetectable, and those test results are reportable by laboratories to the Department of Health, and that's within 3 days. All the lab requirements are within 3 days. Now the last one is referring to, for providers, HIV-exposed newborns. And again, that is any infant that is less than 18 months of age that is born to an HIV-infected woman. That event is reportable to the Department of Health within the next business day. Now, there is no lab test for a birth, obviously, so labs are not reporting those births, and that's why we look for the providers to cooperate and report those births to your health department in your HIV/AIDS surveillance office. You'll notice there, though, there is a section next to that that talks about HIV tests in those that are less than 18 months of age, and again, those positive or negative, those are to rule out HIV infection in those that are exposed to HIV, or rule in a true positive HIV child if born to an HIV-infected mother. So those results are used as part of the case definition for HIV, and those results labs do report to the Department of Health within 3 days. So what methods do we use for reporting? We have passive and active reporting. Good surveillance systems have both. Passive means that your healthcare provider or your laboratory are reporting cases or those lab results to the state and your local health departments. And then inversely, an active reporting system is your state or your local health department surveillance official is contacting the healthcare provider and the laboratory to obtain the case report and the lab results. And good systems have both. We look forward to the cooperation of providers and laboratories, and then inversely, if we can provide something to you, references, resources, we're there for you as well. So this is the overall flow of surveillance information. So this is just to show you what happens to the information once it's reported. So people with HIV or AIDS is the starting point if you look at the far left corner. And then the sources of reports, so hospital practitioners, private practitioners, STD clinics, public clinics, community-based organizations, laboratories. These are all sources of information, and that information is then aggregated at your local county health department or your lead surveillance in HIV surveillance, your lead surveillance county for your area, and I'll show you a map of that in a moment. We review the information, we gather the information, we look at it for completeness and accuracy, so garbage in, garbage out when you look at data analysis. So we want to make sure we're collecting accurate and complete data. If follow-up is required, if there's any missing variables, that's when your local surveillance officer will be contacting you, possibly as a provider, to answer any of those questions we might have. And then when it's aggregated at the local level, it then goes to our state health office, where they maintain the main system, pardon me. And at that point, there are other quality assurance measures that occur, deduplication, done at the local and at the state health office level. We want to make sure that we're not duplicating cases. We have various checks and balances, searches by names, and so forth to make sure we're not duplicating cases, dates of birth, so forth. And then that data is stripped of any patient identifiers, and then that data minus identifiers is transferred to the CDC, where they maintain the national data set. The data is then also aggregated and disseminated. We're not collecting it just to house data for nothing, so we're going to use it, we're going to disseminate it. That goes out at the national level by the CDC, it goes out at the state level by the state health office, and even your local surveillance departments have data that they submit. out for public consumption. And that can be in the form of webinars like today. It could be on slide sets, fact sheets, bulletins, so various sources. So I encourage you to use that data. So how do I report? How do you report? Basically, you can fill out a CDC case report form. It is a 4-page form, but our surveillance office also wants to make it easier for healthcare providers to report. So you're welcome to also call your local Department of Health HIV surveillance office. What we don't want you to do is not to fax. Our internal security and confidentiality policies prohibit providers from faxing any case report information to our offices. We do not accept faxes, and we don't send faxes out and with anything with confidential information. So please do not fax. Please call our office. So this is the, I know there's a lot of information on there, but this is just a map to show you how surveillance is structured in the state of Florida. There are field offices that are divided into areas. You notice area 1 to 15 with subsets for, like, for example, area 8 is A, B, and C. And what this does is divide the areas of responsibility for the field offices. So area 6, for example, my area, we're based here in Tampa in Hillsborough County, but we're also responsible for reporting or responsible for overall reporting of cases in Hillsborough, Hernando, and Manatee counties. So if you report to your local county health department, that information is forwarded to our office in Hillsborough, where we're responsible for that complete and timely reporting. I put the names, and again, the resources will go out, of the lead person in your area that you can call to report, or the lead person. It could be one person in that shop. So in areas with low morbidity, it's one person that's covering a multi-county area. Other areas with moderate to high morbidity, there are, a staff of more people, but this is the contact person of the person in your area that could refer you to the correct person, or take that case report information should you have an HIV positive, HIV, AIDS, or an exposed newborn to report. So before we go into the case report form, I wanted to make sure I covered confidentiality, because this is the most important aspect of what we do. The information we receive, we treat it as if it were our own. We treat it with dignity and respect. So anything that's reported to your local county health department is kept under security. There are physical barriers and different barriers that we use to protect information. So for example, information is double locked. We have limited access to our office suites. In the event someone does need to enter the suite, even a repair person, even the trash pickup, everything is locked up and that person has to sign in. So there are multiple layers of security that protects the information that we collect. And then there are state laws, and the CDC also has some recommendations of all county health departments that we implement. So patient and physician names and personal identifiers are reported to your state and local health departments, but again, they are not sent to the CDC. And then that data is maintained at the CDC and protected under federal assurance of confidentiality. And then HIPAA. So you might ask, do I need my patient to sign a release to report the case? And the answer is no. Diseases of public health importance, or public health reporting in general, is exempt from HIPAA. Here's another guide for you, and we'll send that out in the resources as well. So you are protected as a healthcare provider when you report, reportable by law and HIPAA exempt. Okay, so here is our case report, at least page 1. I'll go into each section, so I know you can't see it all right now, but this is the adult HIV confidential case report form. The adult form is used on any patient that's the age of 13 or greater at time of diagnosis, and it's used to report all cases of HIV infection regardless of the stage of disease. So if you're saying, oh, I have an AIDS case to report, they're AIDS defining now and not HIV, it's the same form. HIV infection is HIV infection now, regardless of that stage. So at the top of the form, we're collecting patient identification information. Again, this is name-based reporting, and it's not transmitted to the CDC. I don't know if you can see it very well on the screen here, but there are those variables that have an asterisk, and those are the ones that are not transmitted to the CDC. So again, first name, middle, last names, we have social security numbers, phone numbers, medical record numbers. None of that is transmitted to the CDC. And those variables are all used in our deduplication efforts. This is a local use only field, but I wanted to point it out that we are tracking how our cases are being reported actively, passively, is it follow-up, and by what medium. You know, are reports getting mailed, phoned? So we're looking at all of that to better our surveillance program. And then we also record the facility that's providing the information. In most instances, it's the same as the facility of diagnosis. There is another section that actually has a separate facility of diagnosis should that occur, but in most cases they are the same. Again, that street address, phone number, and that information itself is not sent to the CDC. The facility name is, but the specifics are not. And then we ask that you just indicate what type of facility you are, inpatient or outpatient, and then there are subcategories for that. And then the date the form is completed and the person completing the form. And then there's a section with patient demographics and residents at diagnosis. And why residents at diagnosis is important, if you notice, the first one was their current address. This is residents at diagnosis, and that's how cases are assigned. So when we look at our data and say so many cases in Hillsborough or Florida or the nation, it's all based at their residents at time of diagnosis, regardless if they moved afterward. And so the patient demographics include their sex assigned at birth, their country of birth, date of birth, if they have an alias, their vital status. If they happen to be dead, we're collecting that date of death. Again, that's part of the full spectrum of surveillance. And then their current gender identity. If it is a transgender male to female or female to male, please indicate that. And then their race and ethnicity. And these are variables we must have in order to report a case. Also very important is mode of transmission. So this is their risk, these are their risk factors. How might they have contracted HIV? Did they have sex with males, females? You check, this is a section where you check all that apply. Have they injected non-prescription drugs or received clotting factor for hemophilia? And then you'll notice there's a subsection that's specific just to heterosexual relations, and it says with any of the following. So we need to know, was there heterosexual contact with an IV drug user? Was that heterosexual contact with a bisexual male? And it goes forth into the different subcategories also to include partners that may have had hemophilia or a transfusion recipient with a documented HIV infection, again, and then, or did they have a partner that they knew was infected, but they don't know how their partner was infected? So you want to make sure you check all that apply. And this guides our prevention efforts very heavily. How do we know where to go to prevent the disease and what communities and what populations if we don't know how they got infected? And then laboratory data. This is the most recent case report that now reflects those changes in the diagnostic algorithms that labs now use to report HIV, where we're picking up those acute cases and then differentiating between HIV-1 and HIV-2. You'll notice that it's broken up into those sections, so non-differentiating immunoassays and then differentiating. And then we have a subsection for those combo tests. Is it an antigen-antibody combo test, for example, that are used in the screenings now in our fourth generations that pick up the acute cases. But I know this form looks very busy. If you need any help with it, please do not hesitate to call your local surveillance officer in our office. We deal with it all the time. Or sometimes we just get questions about interpreting lab results. The fourth generation algorithm can be a little confusing, so please do not hesitate to call. We can help you with that. This is a continuation of the laboratory data. And so this is where we have our HIV detection test that might be qualitative in nature or quantitative. So did you have a detectable viral load or undetectable viral load? And we'll want to list those as well. And then your immunologic criteria, so CD4s when your patient is in care and treatment, what is their closest to their current diagnosis or first. And so please list all of those that you might have available. And at the very bottom, I know, again, it's very hard to see probably for you, but there is a section that has the last documented negative HIV test. If you have a patient that tests routinely, and hopefully you do, and they have a negative, we're looking to find out when their last negative is. And this is where we use to estimate the incidence rate in our population, so the number of new cases. This is the clinical picture as it relates to opportunistic infections. So these are the AIDS indicator diseases. There are 26 in adults, and you'll just indicate that with a month, day, and year. And then we'll also indicate treatment services and then referrals. So has this patient been informed of their infection? Very important. We have systems in place within the Department of Health where we have disease intervention specialists that will go out and contact patients that are newly diagnosed and offer them an array of resources. We're going to make sure that they're first of all, are they aware? Possibly you have a patient that doesn't want to come back into the office. They maybe suspect they might be HIV positive and they're just not returning your phone call or responding to a letter that you might send to their home. Maybe they left a hospital against medical advice, or they were discharged prior to the HIV test result coming back. So this is where the disease intervention specialists at the Department of Health will come in and try to locate the patient, inform them of their results. Also available are anonymous partner counseling and referral services. So anonymously contacting the partners of your diagnosed patient and making sure their partners are tested as well. And that is actually indicated in the next section, where the patient's partners, how will they be notified about their HIV exposure? Is that the health department? Are you as a physician going to do that? Or is the patient going to do that on their own? For females, please indicate and ask if they are currently pregnant. We know we have the perinatal program here, so Hilda would be happy for me to say, please offer testing to your HIV or to your pregnant patients in the first and third trimester. And if they are in fact pregnant, are they receiving gynecological or obstetrical care, or if they've delivered the information relating to their child. HIV antiretroviral use history. Okay, so this is extremely important to show if our patients are in care and receiving treatment, and then also assist us in seeing if they're staying in care. So simply, have they ever taken any antiretrovirals? Now, this is not just for HIV treatment. You'll notice there are subcategories. So if it is a patient you're treating for HIV, you would want to indicate that, and that's in the first box, the date that treatment began and the date of last use. They could be still on the medication, but that's just the date of the most recent time that they were prescribed the medication, for example. And then PrEP, that is pre-exposure prophylaxis. So is this one of your patients, or a patient that you know that by history has told you that they've taken pre-exposure prophylaxis to prevent being infected with HIV? Or PEP, post-exposure prophylaxis, have they taken those at any time? PMTCT is to prevent mother-to-child transmission. Were they taking medication solely for that purpose? Or HBV treatment, or any other antiretroviral use that is not specific to HIV. And then we have an HIV testing history. And again, this allows us to do is to determine testing patterns and then when someone may have been actually infected with HIV. So when you're diagnose a patient, that doesn't really tell us when they were infected. They could have been infected a month ago, a year ago, 10 years ago. We don't really know. So by obtaining testing history, that allows us to use, again, at a population level to estimate incidence rates. So Hopefully you're testing your patients and offering testing to all patients. We want to test everyone and remove the stigma of HIV testing. And so if you know that history, that previous positive HIV test, if they've had one, and this is prior to the one you're reporting, so if they had a prior test, perhaps they came in from another state and now they're in Florida and establishing care with you, you want to indicate the date of that test. If they have a negative testing history, you want to indicate that and the date. If you don't actually have that lab and maybe you just have the year that was done, that the patient's able to tell you that, that's fine. Try to collect as much information as you can to the best of your ability, and you can indicate just a year if need be. And then the number of negative tests within the 24 months prior to that first test. And then of course we have a comment section, that's where we'll indicate if they have a prior history in another state, if we'll want to put that in there for our state health office to then try to deduplicate with other states in order to have good clean data. Now the pediatric form is extremely similar to the adult form. I'm not going to go over every section again. I'm just going to point out what those differences are in the pediatric form. Collect all the same demographics. And so the risk section, or the mode of transmission, is of course then a little bit different. We want to find out information if this person was perinatally infected, what the mother's risks were, when was mother tested, or when did she find out about her HIV infection status, and that's at the very top there. And then her risk factors are also, again, this is the biological mother, her risk factors for that. And then if the patient was not perinatally infected, there's a section to indicate if that child had, injected drugs, for example, non-prescription drugs, or received, transplant with tissue organs that it might have been affected, or they had sexually acquired the disease themselves. So those are all the same risk factors on the adult form that are possible as well. And then clinically, the opportunistic infections just differ a few. There are a few that like LIP that's different in children, but there are, and then repeat bacterial infections, but there are 27 OIs in children as opposed to the 26 in adults. That might make a case AIDS defining. And then treatment and again, these referral services. We collect a full birth history, everything from a perinatally infected case, where were they born, where that facility was, the birth history as far as their birth weight and so forth. Did the mother receive antiretrovirals prior to pregnancy, during pregnancy, and then also did the child receive them afterwards, and what type of referrals were made for the child. Are they receiving any sort of prophylaxis for PCP? Were they breastfed? And then who the child's primary caretaker is. So those are the main differences for pediatric cases. So ultimately, why is reporting important? Why are we collecting all this information? It's just not to collect data and do nothing with it. Our surveillance data helps us ultimately make these inferences toward the whole population. So we're monitoring the prevalence of HIV/AIDS to then, and the morbidity and mortality to then hopefully guide our prevention efforts. We're using it to estimate incidence of HIV. So are our cases going up? Are they going down? Are we preventing the spread of the disease? We're going to modify those trends. Is it going up in a particular population? Is it going up in a particular gender group, race group, risk group, age group? Is it a population can also be defined geographically? So we want to look at the data to see where the disease is occurring, or not occurring. Hopefully we're preventing the spread, and then how can we prevent the spread if it is increasing. And then it also assists our decision makers, whether that's a government official or someone at a community level that's looking to implement some sort of prevention. Then it guides our decision makers in making these public health related decisions. And then importantly, also helps them allocate funds. So if we can show that we do have the need for funds for patient care and prevention efforts in our local populations or at a state level, we need the data to support that. We need to prove that. So that's what the surveillance data does, and that's what you help us do. And then also implementing policies, prevention policies, treatment guidelines, anything that might affect our community as a whole. And then of course it's required by law, so that's another good reason to report. But ultimately, our Florida Department of Health mission is to protect, promote, and improve the health of all people in Florida. So by providing this information, we're ultimately able to achieve this mission. So anyone who's taken a public health class may have seen this quote by our statement by Dr. Faggy, William Faggy, who was credited with devising the global strategy for eradicating smallpox in the 70s. And what he stated was the reason for collecting, analyzing, and disseminating information on a disease is to control that disease. Collection and analysis should not be allowed to consume resources if action does not follow. So what can you do as a healthcare provider to actually act? Well, this is what you can do. In 2006, the MMWR released by the CDC recommended that routine and voluntary testing be performed for patients from the ages of 13 to 64 years of age in all healthcare settings. We would like to see HIV testing become a routine part of your yearly blood work. We want to remove the stigma that's even associated with HIV testing, and we want HIV testing to be, routine. Know your status. Are you positive? Are you negative? If you're positive, where can I get care and treatment? So that as a healthcare provider is what you can do. You can institute routine testing for all patients, regardless if you perceive them to be at risk or not. And then for those patients that are at higher risk, then to do repeat testing more often if deemed necessary. And that's up to the provider's discretion, of course, or if requested by the patient. We're going to get into the resources now. And so this is a resource that was developed by the Florida Department of Health, and we'll send those out again if you request them. But it's a provider's guide to reimbursement and sustainability for HIV testing in Florida healthcare facilities. It's about 2 or 3 pages long, and it's got coding guidelines and so forth, so that could be helpful if you test in your practice. And then, of course, there's the CDC website, cdc.gov/HIV. There's so much information there, prevention to data, so I encourage you to visit that as well. And then this is where you can go to get your case report forms, your adult and pediatric forms. Remember, reporting those perinatally exposed infants born to HIV-positive mothers. You can do that with a pediatric form or calling that event into your local health department. You can also find some of the forms on your local surveillance health department sites under the surveillance section. And then the surveillance case definition is here as well on this site. FloridaHealth.gov, of course, and FloridaAIDS.org. There's a lot of information there, including the healthcare reporting, the practitioner reporting guidelines, and the lab reporting guidelines. We also have information on ADAP, which is the AIDS Drug Assistance Program. There's prevention and patient care information, surveillance, which has our HIV data center, and then minority initiatives that we're instituting throughout Florida. Florida Health Charts is awesome. It's our community health assessment resource tool set. And it's not just for HIV or AIDS. You can go in there and query by county and areas and any number of diseases and conditions that could be impacting your community. And then we have a multimedia campaign in the state of Florida, knowyourhivstatus.com. And there's a lot of great information on there that, again, from testing to prevention, or if you are infected, what to do to keep yourself safe and healthy. And then 1-800-FLORIDA-AIDS. There's my information, of course. You can always email me, call me. After this webinar, I'm here for anyone that might need it. And if you need resources, I can send those out to you as well.